All right, friends, we are going to hop in on our chapter about treatment. And these lectures will probably be a little shorter than most of my other ones have been, or at least shorter than my last one was, because I know that one went a little bit long. Um, we'll spend today talking about sort of how does therapy work and what does it look like in our current day and age. And then we will go over some of the different kinds of therapies that exist um, next time. Okay, so what are we talking about when we talk about therapy? How did we get where we are? What's going on? Well, you do have two basic differences, or I guess I should say one basic difference in what treatments get given and why, and it has to do with the perspective that treatment providers bring to the table. Are their perspectives biological in nature or are they psychological in nature? If they're biological in nature, much like we talked about last time as we talked about the different perspectives and how we understand disorders, um, the treatments that you seek are going to be biological in nature. And this sort of came about over the course of several centuries, really. Excuse me, starting right around the 18th century, we began to have advances in our understanding of the body um, and in how to treat disease, the development of germ theory a little bit later on. Um, is just part and parcel of this increasing understanding of the systems of the body and how to treat them in order to eliminate disease and lessen symptoms. Um, this, while this was mainly medical in nature in the beginning, as the field of psychology began to grow towards the end of the 19th century and into the 20th century, that was immediately applied to the understanding and treatment of mental disorders as well. And at the same time that we had this increasing understanding of the body and the brain, and so we'd get more effective medications and other biological treatments meant to treat the body, uh, on a separate track, you've got psychologists and researchers of the mind uh, creating more specific and more detailed understandings of how the mind works and how to um, affect those systems. And so you get the psychological perspective and a bunch of different modalities developing over the course of the 20th century. And so we'll talk about some of those next time when we're talking about the psychodynamic perspective and the humanistic perspective. These are perspectives we've been talking about the entire semester, of course, but we'll dive in a little bit into what each of those perspectives means in terms of how they think we should treat mental health disorders. Um, Regardless of your perspective, what we try to focus on these days in psychology, especially in clinical psychology, is what we call evidence based practice, where we are no longer just sort of looking at the world around us as, some of the early thinkers and psychologists would have done, guys like Freud, who looked at the world around them and said, here's what I think is going on, and I'm going to develop a system of treatment based on my ideas. That's all well and good. That's a good starting spot. But what if you have the wrong ideas? As it turned out, Freud did have some wrong ideas, at least to the best of our understanding now. And as a result, you end up with treatment modalities that are not necessarily helpful and may even be harmful, depending on the situation. We want to avoid that. We want to, just as doctors do, or medical doctors, do no harm. And so we rely these days increasingly on evidence based practice, where we first go to the scientific literature, the things that have been studied rigorously, empirically, and have been shown to work again and again in a bunch of different situations. And those are the treatments that we focus on because the work's there, right? You can read it, you can see it, you can replicate it. And so we know we have a pretty good level of confidence that this is a treatment that will work. That is the first of the three legs of evidence-based practice. Now, your understanding of the scientific literature needs to then be viewed through the lens of your own expertise if you are a treatment provider, a clinician, or a therapist of some sort. Now, it may be that there are some really great ideas in some of these articles and some of this research, but that when you apply those ideas to specific people in specific circumstances, they need some tweaking. That comes with the territory of actually dealing with people. People are complex, and things are always a little bit more multifaceted when it comes to dealing with humans than we might like. And so you learn over the course of treating people for years and years what works, what doesn't, what works for these people but not for those people, and so on and so forth. So you depend not only on the research but then also on your own expertise as it develops. Third, and co-equal with the other two, are the patient values and expectations. You can have the best, most effective therapy in the world, but if the patient doesn't want it or can't accept it for some reason, that is not an effective treatment, right? And while we increasingly in our society are moving away from the idea that differing ideas and points of view are okay, nevertheless, when dealing with folks in terms of psychological treatment, it must be taken into account. Um, for example, in the medical field, maybe what your um, patient needs is a blood transfusion, right? But what happens if they are oh shoot, I can't remember, is it the Seventh day Adventists or the Jehovah's Witnesses that think blood transfusions are not allowable? I think it's the Seventh Day Adventists. Don't quote me on that one. I could be wrong. It could be the Jehovah's Witnesses. Either way, you've got that group of folks who, even if that's exactly what they need, they will not accept it. It does not have any place in their faith. They think that it is a wrong thing to do. And so, a good doctor, a good treatment provider, will find something that the person will do that is the next best thing, right? Even if it's less effective, the most effective treatment in the world is not effective if the person will not accept it or won't comply with their medication regime or whatever the case may be, right? So you have to take into account not only what you know as a therapist or as a clinician, not only what people have discovered in terms of research, but also who are you treating? What do they need? What is their life like? And you put all of those things together, and in the middle, just as you see in this Venn diagram on this slide, you have evidence-based practice. And that is what we need and must depend on if we want psychological therapies for mental health disorders to be effective for the largest number of people possible. All right, now who is providing mental health care services? Well, you've got a variety of different job titles, all of whom, in one way or another, are providing some mental health care. Psychologists, of course. I mean that's what the the job title is for. This is somebody who is helping somebody with their mental health issues. Now, not everyone who is a psychologist is created equal, and by which I mean I'm a psychologist by training, but I am not a mental health care provider, right? I am a researcher and a teacher. And so I'm not somebody you would go to if you were needing help, right? Um, However, there are plenty of other people who are psychologists as well, who may even teach at a university, but spend part of their time with their own private practice as a therapist or a counselor or a psychologist. Um, or you may find psychologists working in more clinical environments, whether that's in a hospital or in a mental health care clinic. Um, Most of these folks have degrees in clinical psychology, and those are About half of all PhDs in psychology are given in clinical psychology. Those are the folks who are providing mental health care services. Maybe not all of the time. Like I said, they might be teaching too or doing research on the side, but at least part of their job is dealing with individuals. Usually, when you're talking about clinical psychologists, you are dealing with individuals who are um, treating mental health care disorders, right? So these are the folks who are seeing people come in with schizophrenia or with a personality disorder or with autism or ADHD, perhaps, if they work with children, um, and are treating diagnosed disorders, right? More severe disorders. Most of the time, these folks have a PhD level degree, although there are some who function at the master's level. Um, and that is the bulk of folks who will call themselves psychologists, right? Psychiatrists, we tend to use those two words interchangeably in everyday speech, but it's not actually the same thing. A psychiatrist is someone who has gotten a medical degree, so they've got their MD, and then they continue past that degree with an additional 2 to 4 years specialization in psychology and in mental health care. These are the people who prescribe psychoactive medications, generally speaking. Um, so most psychologists that you go to will not be able to prescribe you antidepressants or um, Valium. No, that is an antidepressant. Actually, no, that's an anti-anxiety drug. Never mind. Or Thorazine for your schizophrenia or whatever the case may be. They do not have prescription rights, privileges, I guess I should say, because they don't have a medical degree. Most psychologists do not. Um, there are exceptions in the state of Arizona, and I think there's one other state as well, Maryland or maybe Massachusetts, where psychologists can get a certification to get um, the privilege of prescribing medication. But generally speaking, you're going to have to go to a psychiatrist to get your medication. Or in some cases, you may just go to your general practitioner, doctor, right? It's the folks with the MDs that can prescribe the medication. Now, there's a whole other realm of folks. Some of them are called counselors, some of them are called therapists, who may have a master's degree, may have a PhD, but are working in private practice for the most part, where they have opened up their own business um, and seek out clients, and then they help them with their problems um, in terms of their mental health. These folks tend to work with subclinical populations, meaning folks who don't have a diagnosis of schizophrenia or a personality disorder or some more severe mental health issues, but folks who are just not doing great in their lives and want to improve things, want to feel better, but may not necessarily have a diagnosed disorder. Um, uh, Folks who tend to be a little bit more functional in their lives, right? But just need a little bit of extra help. Social workers, although you may not necessarily think of them as mental health care providers, end up being on the front lines a lot of the time. Generally speaking, these are folks with a master's in social work who, for the most part, work within the government system in one or another government agency to provide people who are interacting with government services with mental health care services and other services as well. So these might be folks who are going out to check on somebody's house because the neighbors have called child protective services because things aren't going well there, and who will assess the situation and um, decide whether or not the kids should stay in the house and whether or not the parents need additional help and services. Folks who are in court ordered drug programs and need to check in with somebody on a regular basis to make sure that they are complying with the judge's orders will frequently go to a social worker on a regular basis. And these are then folks who are providing care for people who tend to be in the lower levels of socioeconomic status and have some of the greatest needs in terms of being able to manage their lives. And so, honestly, even though they tend to be low-paying jobs, I have great respect for these folks because they work hard and much like you know our high school and elementary school teachers don't get paid nearly enough for it. Couples and family therapists are sort of I put under the same header with counselors, where they are providing mental health care services to families and couples in helping them manage their relationship problems, even though probably the people involved don't have mental health disorders, but they just need some help figuring some stuff out, right? You have a couple of other categories that aren't listed here that are worth including as well. Clergy tend to be involved in mental health care, whether they might like to or not. Um, whether these are folks who are paid or are volunteer positions, because that varies widely depending on your religious tradition, um, that tends to determine how much training these folks have gotten in mental health care services. For instance, I come from the LDS tradition, as is common here in Utah, where the leaders of congregations are volunteer positions that people fill for a few years and then move on, right? What that means is that most LDS bishops, when folks come in suffering from depression or anxiety, and that's causing, behavioral problems that the person feels that they need to talk to their bishop or their pastor or their priest about, these LDS bishops frequently don't have any idea what to say. If I were in charge of things, I would say, hey, we got to get some classes for these folks. I'm not in charge of things. Nobody's listening to me. In other Christian traditions, pastors, reverends, priests, many of these folks will actually go to school, go get a degree um, that includes study of the scriptures and also, most frequently, um, some classes in human psychology that gives them some idea of what they might be dealing with. Generally, these are Masters of Divinity degrees, and that's what most folks in the Christian tradition, at least, get if they want to be a religious leader. I know less about the religious traditions outside of Christianity in terms of the kind of training that people get. And so I can't speak to those. That's really a gap in my knowledge that I ought to rectify. If that's something that's interesting to you, I'd be happy to talk to you about that and do some research. Um, because there's plenty of folks out there who are not Christian, right? The majority of the world, in fact. All right, anyways, so that's one category of folks who you might not think of as mental health care workers, but who do provide mental health care services in more or less informal kinds of ways. One last category that is unregulated and so ought to be viewed with a little more caution is the life coach category. This is sort of a new thing over the last 20 years or so, where folks can get an idea of how they think people need to behave and set up their own business and without any sort of certification or schooling whatsoever can say, hey, here's how you need to live your life. Give me some money and I will tell you what to do. Um, that's a little scary, but not necessarily a problem, depending on what people are advising, right? There are life coaches out there who have done some real good for folks and helped them, whether we're talking about physical issues or mental issues or whatever the case may be. And then there are others who are, I'm sure, pure charlatans. And so you've got to be a little careful with those. All right. Now, what does therapy look like? Well, these days, it tends to be much briefer than it used to be. We have an idea of what therapy is supposed to look like based on movies and TV, where you go and sit in a dark room and sort of lay down on a couch, and the therapist sits behind the desk and takes notes, and it's a dimly lit room, and they're asking you about your feelings and maybe your relationship with your parents, and et cetera, et cetera. That is a very particular type of therapy, and that does happen all of the time. But you, in this day and age, are unlikely to be going to a therapist weekly over the course of years unless you're paying for it out of your own pocket. The introduction of what we call managed health care um, is something that has grown up over the last 50 years or so in the United States and across the world, as the introduction of health insurance meant that most people were not paying the full amount for the care that they were receiving, first for medicine and then eventually for mental health care services as well. What that means is that the insurance companies who end up footing most of the bill, at least up front, to the doctor or to the therapist, end up having a lot of power and a lot of sway over what therapies get provided. And so they spend a lot of time and effort evaluating which therapies are A, the cheapest, and B, the most effective. And so they will, over time, say, we are only going to pay X amount of dollars for this other therapy because the research says that it is not effective as this other therapy, which takes less time and has better results. And so we'll pay more for this other therapy. And this third therapy over here, we're not going to pay for at all because it doesn't have any research support. Um, Now, in an ideal world, this is great because that funnels healthcare dollars to the most effective treatments. But frequently, it doesn't quite work out that way. It does narrow the choices for most individuals who have their own healthcare because they're paying for their healthcare at least a certain amount every year. Then they don't want to pay additional out of pocket. And so they will go to their approved mental health care providers that their insurance company tells them about, and those folks will only offer them the particular therapies that are uh, accepted by the insurance company. And so you do get a narrowing of options that can be problematic in certain cases, especially when it comes to new therapies. It takes time for those new therapies to be accepted and for the insurance companies to pay for them. And costs go up all over, and I hate our healthcare system, but that's a whole different discussion that we won't have right now. There are different kinds of therapy you can have. We think of a person going by themselves to therapy, and that does happen. That's pretty common. But you may also go with your romantic partner, or with your family, or even with a group. Right now, if it's your partner or your family, well, it's probably a group dynamic issue that needs to be addressed, and so it's most effective to have everybody in the room. But then there are other group therapies where the entire point of having additional people in the group is to defray the cost of the expert in the room, the therapist or the clinician, right? It costs, probably $150 or $200 an hour for a therapist in this day and age. And if you've got 10 people in the room all at the same time dealing with the same stuff, well, then you can pay, 10 or 20 bucks an hour instead of 150 or 200 and still get some help. And it may not be exactly one-on-one, but everybody's taking turns, and that can work out really well. In fact, there are even some group therapies that have done away with the expert entirely, right? You think of 12-step groups like Alcoholics Anonymous. There's plenty of others as well. Where there is no therapist present, there is no expert. It's just people all dealing with the same issue, providing support and advice to each other. And in some cases, the outcomes are just as good in those group therapy kinds of modalities as they are in group therapies that have a therapist leading them. Just depends on the situation and the people involved. Okay, one new thing that has come up and continues to change as our technology changes is more and more folks are doing something similar to what we're doing right now, where instead of showing up to a place and then having a session with your therapist, you're sitting in front of your computer and your therapist is talking to you online. Now, this is great because nobody has to put on pants, and also because the therapist then does not have to pay the rent for their office or the utilities for that office, and can ideally provide services at a lower cost to the individual and with more convenience to everybody involved. And so as our technology improves, you see more and more of that. It's still a little chancy these days. Skype has gotten better over the last 10 years, but you've all had that Skype call where it's like there's a quarter of a second lag and everybody's trying to talk at the same time and then stopping so that the other person can talk, and then you both start again at the same time. It's maddening. Now, try having that conversation about some of your deepest fears and most closely held anxieties. Not awesome. So there's still improvement to be made there. But as that gets better, as our technology becomes more seamless, um, I have no doubt that that will continue to increase in uh, prevalence and in prominence. Okay, that's sort of how psychology therapies work today and who's providing them. So I'm going to go ahead and leave it there, and then we'll come back to different styles of therapies next time and go through all the different ones. Okay, thanks everybody. Have a good one. We will talk to you soon.